everyone, and welcome to today's wonderful evening with Dr. Chandrasekhar Sir. Dr. Chandrasekhar Sir had been one of the most passionate and eminent teacher, and we had a great privilege of having many sessions with Dr. Chandrasekhar Sir. Very few ENT surgeons among whom I know so passionately, lovingly teach the students. And today it's my wonderful opportunity to become a student once more, to learn the ENT from the words of an ENT teacher and a medical specialist. Today we have Rishabh Shetty, Avinash Reddy, and many more who are all online. So we are going to have a very rapid fire session of around 50 questions in ENT, so that it's like Jugal Bandi between two teachers, in fact. So please keep punching your answers also, the online students. So, sir, a couple of words from you about you. Many students know, a large number of students are your fans. Yes, sir.
Sir, that is all because of the opportunity provided by you. There is a saying from Gita that Bodhayanta Parasparam Kadayam Tasyama Nityam Tushyanti Charam. The great people who are the Pandits, they share the information to people so that it can be transferred mutually. Nobody is perfect in anything. Everybody has to learn from someone. And I owe all this to you because you are my guru when we were running for your classes. And from such a big stage, you have given me opportunity to be with you. So that's enough. That's a great thing for my life. That's it. I always feel like that. And you are one of my guru, as Gita, like Krishna and Arjuna. You're one of my gurus. Sir. Thank you very much for providing the opportunity. Always welcome. If you are giving opportunities, we are ready to serve the students. Sir. At the end of the student should get benefits. Yes, sir.
Wonderful, sir. Thank you so much for the kind words. And we'll have, in fact, many more sessions. And yes, sure. Of late we started this tradition of yes, tradition of the two teachers sitting like classmates preparing for the NEET PG exam and having a debate, which is a wonderful way of learning. So to start with, what are the arteries that supply the tympanic membrane, sir?
Tympanic membrane, sir, it's a tricky thing. Actually, it develops from all the three germinal layers, and it has got supply from even both the things, sir. Like the ear has got supply from both external carotid and also internal carotid. What I say here is one you have to remember as atma. Atma. You should remember the atma. That is the anterior tympanic artery of the maxillary artery. That is the most important branch that is helpful. So rest all, as you could see, all branches of the maxillary artery and external carotid artery. So the most important is the maxillary artery. Atma, you remember as Atma. This is important. Why? Because when the tympanic membrane is showing cartwheel appearance, all those branches are all belonging to this anterior-tympanic artery of maxillary artery. And it is as anyhow I told you that it is seen as a cartwheel appearance in the acute suppurative otitis media, in one of the stages of the acute suppurative otitis media. And as a whole, tympanum is the middle ear, as we know that, and then it is being supplied by posterior auricular artery also, and middle meningeal branch also, like from the skull, inside the skull it is coming, and a twig from the internal carotid artery is also coming.
Great. So, what is the nerve supply of tympanic membrane? What is the trick of remembering it?
Nerve supply, sir, it's like, you know, I don't think any other body part is supplied with these many cranial nerves like ear, as you know that, so anteriorly, so 5 in front, 10 behind, and posteriorly 7. Just keep it like that, and medially 9. So if you are having any pain right from the middle ear, it will radiate towards the throat, as by means of your glossopharyngeal nerve. That is the Jacobson's nerve. That is also in the bed of the tonsil, it is present. And second thing is anteriorly. Anteriorly, if you take anteriorly in front, like crocodile festival, in front there is auriculotemporal nerve, 5. Behind, so 5 into 2 is 10. Okay, something like that you can remember. Behind is 10. And posterior-superiorly, as you know, seventh nerve is also involved. As you know that in the house itself occurs sign. So it is lost. Sensation of the posterior-superior part of the meatal wall is lost in the acoustic neuron which is pressing the seventh nerve. So posterior-superior sensation also lost. And medial to the tympanic membrane, it is a glossopharyngeal nerve. That is ninth cranial nerve. And as you know, the promontory is having that tympanic plexus also. That is, those are all the most important things. So no one can say that this is the only part in the body which is being supplied by most of the cranial nerves. These many cranial nerves for this much small organ. I don't know how sensitive the ear should be, as we think according to this. So, and once again, when you are trying to poke the posterior part of the canal wall, you should be very careful because it might stimulate the bradycardia. And patient, at least so 1 in 1,000 patients might fall down when we are doing syringing. Also, that should be kept in mind because of vagal stimulation.
Great.
I hope this is information.
So the posterior wall is supplied by the vagus. That's the reason whenever we are operating, there is a chance that the vagomimetic effect can lead to development of bradycardia. Wonderful. Now, perilymph versus endolymph is a lot of times one of the favorite MCQ. So can we fill the blanks in?
Yes, sir. Here only I'll give the Indian flag concept. In the middle white, above is orange saffron, below is green. So white color is the endo part, endolymph. Okay, as simple as that. And perilymph is surrounding both the endolymphs. Of course, this Indian flag concept, it's like a tube. So the endolymph is surrounded by perilymph. Endo is inside. Inside more is potassium. So peri is outside. Outside is sodium. That's as simple as that. So nothing much more to understand in this. So it's as simple as that concept. And this particular endolymph tube is nothing but the cochlear duct, which is being surrounded completely by your this perilymph. So as you can understand, as simple as that. Sodium sodium outside and perilymph inside.
Great. So endolymph has potassium and perilymph has sodium, and peri is outside and endo is inside. And endolymph is produced by the stria vascularis of the cochlea and by the dark cells. Now,
Yes, sir.
what is the auditory pathway, from where it starts, where it goes, and is there any way to remember this?
We can just say, so fans of Virat Kohli can remember, like Kohli or E. coli can also be remembered. E. coli MA. So Kohli has read MA, so that is Master of Arts. So E. coli MA. EE is like when you say at the end of the day, A is the auditory cortex. It has to go to the Brodmann's area, the temporal lobe, etc., etc. E is the eighth cranial nerve. As we know, it will start as a distal part. Distal is the one which is below, is it or not? If you are plucking a fruit from the plant, okay, from a tree. So the one which is available to us is the distal part. So the one which is above is the proximal part. So from there it goes towards the branches, and then it goes towards the trunk, and then it goes towards the root. So I can just remember as simple as that. E. coli MA, the same. Don't remember as E. coli MA. E. coli MA will be useful for BERA also. Same thing, like as you can say, we'll see the bits in the BERA also. So E. coli, eighth nerve, distal part, proximal part, and then superior olivary nucleus, lateral lemniscus, inferior colliculus, medial geniculate body, auditory cortex. So of which this 5 and 5th wave is the most important thing, that is especially from the lateral lemniscus that we say in the BERA. So it is very important. Why? Because it is like when we are trying to see whether the pathway is existing or not is one thing, and physiologically functional or not. So like heart is giving electrocardiography, ECG waves. Some waves are produced by all these parts of the auditory tract. Okay, so that we can pick up the part which is not functioning, whether it is cochlear or retrocochlear, etc., etc. We'll be discussing the future bits. So E. coli MA is most important.
Great. And in fact, one very common way to remember is the geniculate body happens to be medial. Geniculate body is located nearer to the midbrain, and auditory is ears, which are lateral. But actually, geniculate body happens to be medial. And because geniculate body became medial, lemniscus happens to be lateral. So that's the point. And among the colliculi, superior colliculus susteri, inferior colliculus interi. That's what we used to remember. Superior colliculus susteri. It will watch. That's the reason it is a visual pathway. Superior colliculus sees. So visual pathway. Inferior colliculus Intadi. In Telugu, intadi means it listens. So it is auditory pathway. Very good.
So one more thing, sir, to add for that also, the lateral geniculate body and medial geniculate body. So eye and the superior is related to that medial, and then this is that the superior is related to that lateral, and this auditory is related to medial, sir. I hope you got.
Yes. And in cochlea, is it higher or lower frequencies in the basal turn, and is it higher or lower in the apex of the cochlea?
So as you go up and up, sir, like you from 20,000 to 20, you go up, sir. So it is just like a staircase, as you know, in the modulus it will be there, and around it will be going up, and then it will be decreasing in the order, like as you could see. So basal turn of cochlea and this one.
So the basal turn typically will have the higher frequencies and progressively lower turns towards the apex of the cochlea. So that is how it is commonly remembered. Now, how do we differentiate the deafness because of a problem in the cochlea versus retrocochlea? So what is the story about this very important MCQ in the exam, sir?
Yes, sir. Based on this, the retrocochlear and cochlear, sir. One thing simply is that the cochlea is, I just say the student that cochlea is like an antenna. Nowadays, people know the DTH antenna. So it's like an antenna, and the cable comes from the antenna, and it is the retrocochlear. Just you can just remember like. So in our days, we used to have antenna. If any crow stands on the antenna, we used to have disturbance in the TV. Okay, these kids may not be knowing that, of course, but DTH is there. That is one way that you can say. So cochlear, retrocochlear, especially once you should have some basic idea about the examples. Cochlear is Meniere's disease. So cochlea has got once again same thing like an Indian flag, as you should know. So that the three compartments are there. So endolymph is the white compartment of the Indian flag. It is going to swell up, and then it is going to give some amount of distortion. So as you know that this cochlea is having these hair cells, etc., and it is going to have some amount of cochlear nerve that is going to be formed, and it is going to form into the cochlear nerve and then form like that. And then retrocochlear is beyond that. As you can see, once this particular sensory part is over, the neural part is going to come there, and then it's going to get damaged. Retrocochlear hearing loss, especially the example will be acoustic neuropathy. These two can be the basic prototype example that can be remembered as simple as that. So as you could see, so when, for example, there is something like when a crow is standing on that antenna, what happens is the distortion. Like as you could see in Meniere's disease, we have to say that the hearing increases and decreases, slowly adding upon of that particular hearing loss will be there in Meniere's disease. And retrocochlear hearing loss is something different, which is related to the nerve-related hearing loss, as you could see. And there are few tests which we can be able to remember as simple as that, as you could see here in this. So CCC, you can just remember CCC is cochlea. Okay, CC, short increment sensitivity index. So you can just remember it is given as SI, but you can just say CCC. Okay, CC is C. That's it. So short increment sensitivity index is positive over here. So threshold tone decay is related to your retrocochlear pathology. So threshold tone decay. So I remember I say to the Telugu students especially, TTD is a board that is present in Rayalaseema. RC is Rayalaseema. As simple as we can never forget that. So TTD board, that is Tirumala Tirupati Devasthanam, is threshold tone decay. It is present in RC, that is Rayalaseema. It's not in Andhra or Telangana. So you can just remember like that. So just this is a very big confusion. Always they make the mistake, they lose the mark unnecessarily. There is nothing much to know in detail about these tests. Why? Because this is audiological investigation. Even the ENT surgeons fail to understand this. So we have to just remember which test is positive and what. Okay. So it is just like a battery of tests that is being done in this particular. You can just remember like that. So when you have got rollover phenomenon. So rollover phenomenon is like once it increases and then later on decreases. The rollover curve, that is in the speech that audiometry, the rollover curve will be there. That is there in the, especially in the case of this retrocochlear pathology. So rest all those things are very simple. Speech discrimination score is also impaired. Speech discrimination score is impaired means, so the changes in that particular decibel level, it cannot be caught up properly, especially in the case of retrocochlear pathology. So these two are the most important. CCC is cochlear, and this TTD and the rollover curve. These are the most important things which you have to keep in mind. Going deeper into the subject, we'll tend to forget the surface unnecessarily, which is not needed for NEET type examination. Okay. It's an audiological subject. We have to do MSc audiology. You have to master that. Even we also stand a foot behind to understand that.
Wonderful. So one very easy thing to remember is SI is positive. SI, you can remember C is there in C. That is cochlear. That's a beautiful point. Then another important thing is the speech discrimination is highly impaired. Already Chandrasekhar sir said TV is retrocochlear, antenna is cochlear. So TV is retrocochlear. So that's the reason if the TV is not working, you cannot listen the sound or anything. So speech discrimination is highly impaired. You can easily remember. Then once upon a time, old TVs, we used to change the channels for which we need to roll. So rollover phenomena is what you see with the TV, which is retrocochlear. So if you remember antenna as cochlear and TV as a retrocochlear, many problems get resolved. So this is a wonderful way to remember. Now, how do we classify the hearing loss in WHO?
So this is one thing which is followed by different protocols. They say Goodman and Gilman. They say WHO. So WHO level is enough for this junior level. So they say normal, mild, moderate, severe, total, profound. This is the regular thing which we follow in ENT practice. But according to this, you can just say 26 to 40. So till 25 it is normal. You can just say that. Some people say till 15 only normal. That is a high-end classification, which is not necessary. So 25 decibels. That means a sound equivalent to 25 decibels. If he is able to hear, it is 20 is normal, and 26 to 40 is mild hearing loss. Moderate is 41 to 55, 56 to 70, 71 to 91, greater than 91. So greater than 91, profound, you can take it like that. So this is something to remember in practice.
Now, masking is required for air conduction whenever the difference between the healthy and deaf ear is at least how many decibels? And in all such cases, is it the better ear or the suspected deaf ear which need to be masked? Actually, what is the story of masking?
Masking is just like copying, sir. Simply in the examinations, people tend to copy. We ask question to someone and then answer is given by someone. Okay, so we ask question to a normal average student, the answer is given by a brilliant student. They give the answer very fast, something like that. So normally here, so that is the non-test year. They call it as non-test year. So test year and non-test year. If it is more than 40 decibels, we will have some problem. Like, so when the difference is more, the other ear starts catching. So you use something called as a Baroness noise box. Baroness noise box to mask the non-test year. Just remember like that. Conceptually, if we go deeply, we forget the surface. So just we have to say and remember. According to entrance examination, you have to remember something and then answer the thing. That's it. Nothing wrong in writing answers like this.
Great. So masking is basically done in the better ear should be masked, and at least the difference is 40 decibels. It is simply like this. If a bridegroom is coming to see the sister, there is a elder sister and a younger sister. Elder sister happens to be more beautiful. So that is the reason generally what they used to do is they used to mask that younger sister so that the bride groom will ultimately say okay to the elder sister. So that's anyway. Sali Adi Patni hota hai is what they say, even if it is masked, no one can help her. So now, in pure tone audiometry, what is this in pure tone audiometry? What is this graph basically? Is it normal or abnormal? If so, then how do we interpret it?
So we have first to learn the basics, just simple as that. So when you go to a temple, the bell is hanging vertically. So decibel is there in the y-axis. You can remember like that. So decibel level is there in the y-axis and frequency is in the horizontal axis. So how many times you roam around the temple is frequency, is it or not? Is it, you do pradakshina, that is temple. That is the y-axis and x-axis. So bell is hanging vertically. So remember like that. for every decibel level and at what frequency, how much loss is there. That is what is called as pure tone audiometry. Audiometry is measurement of this one. So pure tones, you give pure tones. You don't give any mixed tones like noise. So give pure tones. That is, you will just say that is a 500 hertz, 1000 hertz, or 1.5 to like something like that. So air conduction and bone conduction are two things that are to be kept in mind. So always bone conduction, it is broken lines, B for B, broken lines, and air conduction for straight lines. So all these notations are there. You can just say left to right is greater than or less than, something like that. And air conduction, bone conduction, all those notations are can be practiced, but they will not be asked in the examination mostly. What is the way that you can just say like that? And normally air conduction is better than bone conduction, but according to technicality, bone conduction is always higher than the air conduction in this particular pure tone audiometry. So if, for example, I'll just say a small example here, like normally, as we have seen already, the classification, that is 25 decibels is normal. Till 25, the graph is not falling down, then it is supposed to be normal. So air and bone. So there should not be much gap between the air and bone connection. So here I'll just say two to three small examples. Like people might have visited some exhibition or zoo park. There is a narrow gauge train there. Okay. So there is one thing called as meter gauge train. So meter gauge train is there in our childhood. It was there in our childhood. Now it's all broad gauge. So the gap between the two tracks is increasing and increasing as you go from narrow gauge. And if you say single track is there, for example, like in Japan, so they are running on like our metro trains, they'll be running on single track. So for example, something like that. So if the two lines of 1 year, that is right is red color and left is blue or black color, you can say. So if the gap between these two is very narrow, so almost very nearby, less than 20 decibels. So that is the airborne gap, that is called as airborne gap. So if they are very nearer, then it's supposed to be normal. There is some amount of gap, like something like a broad gauge. So the airborne gap is there. That is, the bone conduction is there, but air conduction is falling down. Then it's supposed to be a conductive deafness. And if air conduction and bone conduction both are coming down, then it's supposed to be mixed hearing loss. So both air conduction and bone conduction are coming down, it's supposed to be mixed hearing loss. So you should see something called as the airborne gap. So in this particular graph, it is almost supposed to be a normal thing. So it is less than 25. You just see whether above 25 it is there, and it is a good thing. So normally, if we get 100 marks, we are good. But in pure tone audiometry, you should be nearer to 0. So why? Because even the slightest of the sound is heard by the normal individuals. So it is the slightest of the sound that is equal to 0.0024 dynes per square centimeter. What they say. In the healthiest individuals taken from all over the world, from 18 to 25 years of age group, they calculated the decibel value. That is the least possible heard pressure level. So based on that, they calculate all this decibel, etc., which is out of scope of this discussion. So in this particular discussion, as Sir has shown this other graph, so this is a broad gauge. So broad gauge means the gap has become more and more. So especially this should be like the airborne gap is become more and more. And as you could see, bone conduction has a broken line. Bone conduction is suggestive of what? Bone conduction is suggestive of sensory neural hearing loss. So if bone is conducting something, it is based on the nerves only. It's not based on the conduction. It is based on the nerves. So bone conduction is intact. That means sensation is intact. And air conduction is falling down. That is something which is going through the canal is falling down. So that means there is an airborne gap which is more than 20 as a arbitrary value we can taking. So air conduction is falling down. We can say it as a conductive deafness. Just as simple as to remember. Broad gauge conductive deafness. Okay. So.
And now this.
This one, sir, this is a pure tone audiometry, a sloping sensory neural hearing loss, as you should see here. Normally in SBV in old age people, so sloping sensory neural hearing loss will be there. And you can see the last one, that is never more than 15 to 20 decibels. So it is just like a narrow gauge. That is the zoo park. I mean, someone might have gone train in the zoo park, especially Hyderabad, Nehru Zoological Park. It is a very narrow gauge built by BHEL people. So very narrow gauge, almost less than 1 meter. So the gap will be very less. But here fall is there. So gap is very less, but fall is there. Fall is there means bone conduction has fallen. Bone conduction has fallen means sensory neural hearing loss. Gap is not there means it is a narrow gauge means it is a sensory neural hearing loss. If fall is also there and gap is there, then it should be called as mixed hearing loss, as you have seen. That means sensory is also there and mixed is also there. So if they are trying to catch down and down and down, it is sloping sensory neural hearing loss, especially in the presbyopic cases, old age people, it will be like this.
Great. So what I understood is the broken line is bone conduction and the regular straight line is the air conduction. They both are very close to each other without any gap if it is normal, and that's the reason it is called a narrow gauge, you can remember. And this is the broad gauge, and there is a wide difference between the two, and that makes typically a bone conductive hearing loss. And in this case, the air and bone conduction are close to each other but fallen together. So that is, it is a narrow fall together, and that
Yes.
makes it sensory neural hearing loss. But if at all they both are falling, but they are widely separated from each other, then that becomes a mixed conduction disturbance. So
Yes.
that is the way to remember. Wonderful. Then another favorite image-based MCQ, which is commonly asked in the NEET PG exam, sir, is the types of tympanograms and where do we see them?
So this is also simplified with my special. I have my own example, sir. We'll just see tympanogram. So tympano is a middle ear. So tympano middle ear is a gram is something which is going to weigh it. That is, it is going to measure it. Okay, as simple as that. So what is the status of the middle ear is given by this tympanogram. Okay, middle ear status is given by this tympanogram. So normally what happens is, as you say, I'll just tell as an example. If you take the normal as A curve, so this curve is based on this compliance and pressure. Compliance is the this y-axis, as you could see here, and pressure is the x-axis. So as you could see, compliance, resistance or impedance, what you can say like that. So resistance and impedance and compliance. So compliance pressure graph is what is measured in this particular impedance audiometry. How much is the negative effect that is produced? So you should say, when I say something to a student, if he follows, he is compliant to me. He is compliant to my words. So please write the notes, means he is writing, means he is compliant. If he is not writing the notes, he is impedance. He is showing impedance or resistance to me. So he is not a good student. So when I say, for example, I put some probe inside the ear canal like this, when I put pressure inside, the tympanic membrane is moving medially. Then the tympanic membrane is listening my words. And if I pull the pressure, that is, if I suck the pressure like a straw from outside in the canal, tympanic membrane is coming towards me. So then also it is compliant. So if you take the graph A, sorry, please point out the peak of the graph A. Peak of the graph A, if you take that, that is zero pressure. Zero pressure means the tympanic membrane is lying like that. So when you are putting a pressure positively, so as you could see, so that positive pressure also and negative pressure also. A graph looks like A only simply. So it is a normal tympanic membrane. When you put positive pressure, like you are pushing air towards the tympanic membrane, it is going medially towards the promontory. When you are pulling also, it is coming each other. So you could say the graph is like a, as you could see in this particular A shaped. So that is A type of impedance audiometric graph, which is there in the case of normal tympanic membrane. And next, when we have to go for AD, especially in ossicular discontinuity. So ossicular discontinuity, what you say is that, so it is just like a adamant student who doesn't listen to anything. So doesn't listen to anything. D for discontinuity. Okay. So when you are giving a pressure inside and outside, why the tympanic membrane is moving? Because it is connected to the ossicles and connected to the round window and oval window as a part of this preferential pathway. Oval window and round window as a part of this preferential pathway. So when there is discontinuity of the ossicular chain, whatever the pressure that you are giving, there is no peak. So there is somehow there is movement, but there is no peak that you are not able to. So peak is at the infinity, as you could see in that. So they are not meeting each other. Ossicular discontinuity. D for discontinuity, as simple as that. A shallow. So for example, ossicular chain has got some sclerosed effect like otosclerosis, like especially the tympanic, the foot plate of the stapes or something like this fixed like that. So it is listening, but not listening completely. So it is listening, but not listening completely. Therefore, A shallow is present in the case of otosclerosis. B type. B type, you just remember Bombay, BOM, bomb. Bomb is nothing but, so B for otitis media with effusion. So otitis media with effusion. So it is like a flat curve. So what happens in otitis media with effusion is there is a water in medial to the tympanic membrane. So when you are giving, so Sir has drawn it like that. So there, there is some amount of negative pressure or positive pressure. The reaction is very less, and it is a flat curve, as you could see. So that only for the sake of that small reaction, you just say flat curve. B type in otitis media. And if you take C type is eustachian tube dysfunction. C type is eustachian tube dysfunction means, so what is happening? The peak is negative peak. Why negative peak is there? Eustachian tube dysfunction, already the tympanic membrane is pulled medially. There is negative pressure in the middle ear. So when you are putting negative pressure in the middle ear, and you also have to pull it towards you, means you have to put negative pressure to get it towards you. So C type eustachian tube dysfunction, B type otitis media with effusion, A type normal, AD type ossicular discontinuity, AS type A shallow otosclerosis. S for S otosclerosis, D for D discontinuity, A is the normal thing, C for eustachian tube dysfunction, B for Bombay. I told you BOM, otitis media with effusion. C is the only thing you have to remember, CETD, eustachian tube dysfunction. C followed by E, followed by T, followed by D. ETD. So that way you can answer these questions.
Yeah. I'll once more. What is the order to remember, sir? First
A, sir. Just say A.
Okay.
A is the normal thing, and
AD.
AD, sir. AD is the ossicular discontinuity.
Yes. Then AS curve, which is
A shallow, sir. A
shallow curve. Okay.
A shallow.
Then comes the B curve.
B curve. B for Bombay. Just remember BOM, bomb.
Okay. And C curve is negative peak pressure with the eustachian tube. Great. So once more, the BERA, the brainstem evoked response audiometry, and what are the various waves is a favorite question. Already, Sir has mentioned E equivalent. E is distal part of eighth nerve. Wave 2 is proximal part of eighth nerve. C is the cochlear nucleus and lower pons. And O is superior complex, lateral lemniscus, which is in the upper pons. And the inferior colliculus is 7th and 8th. Now, what are the scenarios where we do the brainstem evoked response audiometry, sir? Okay, I think Sir will be once more joining back. Yeah. Yeah. I think Sir lost the connection. He'll be joining back. Okay. So meanwhile, yeah, I think Sir joined back. Yeah. Right. Very good. Yeah.
Okay, sir. Sorry for this small amount of technical error, sir. Sir, this BERA, sir, I'll tell simplifiedly. A lion is sleeping inside the den, sir. You want to see whether the lion is functioning or not. So you're throwing a stone. Okay. So lion is nothing but the auditory pathway. Every part of the lion, whether it is functioning or not. So if you are hitting the stone on the head, it shouts. If you are hitting the stone on the tail, it wags the tail. If you are hitting the stone on the body, it moves the body, and hitting on legs, it is moving the legs, something like that. So E. coli MA is the lion here, and you are giving tone clicks or bips sound. So whether it is functioning or not, some waves are produced from that particular parts of the E. coli MA, and of which fifth wave is very important, lateral lemniscus, and each and every part is steady. Of course, this BERA is an incomplete test. If you go into details of it, which is not needed for this level, but whether the auditory pathway is functionally existing or not. So whether the lion is dead or lion is alive. If lion is alive, definitely it shows some reaction. So that is what is about the BERA. It will help us in knowing about the retrocochlear pathology, and because the patient's cooperation is not needed, patient, even in the case of coma or brainstem death also, you can diagnose that. Patient's response is not needed. It is an objective test. We can test it. And you can say cochlear and retrocochlear pathology. And what part of the auditory system is problem, you can say that. Especially in the neonatal screening program, BERA and photoacoustic emissions are the two tests that are being done. whether the child is hearing or not by birth, whether we can do cochlear implants or not. One of the battery of the test is this BERA. So this way you can just remember about BERA simply. Fifth wave, most important, robust.
And as physicians, very commonly, multiple sclerosis is a scenario where visual evoked potentials, if it is optic nerve involvement is there, and whenever the auditory pathway is involved with the demyelinating clots, very often BERA is being ordered clinically, and even for the pontine tumors also, typically because it is the lower part of the pons, where pontomedullary junction is the area where you have the auditory and the cochlear nuclei. Now, this audiogram, where do we see this shape of audiogram in a case of sensorineural hearing loss, sir?
So sloping sensorineural hearing loss, sir. You can see it in presbyacus cases, as you could see. And sometimes, they say Meniere's disease, early stages, it is there. And Meniere's disease, middle stage, it is straight. And then later on, Meniere's disease, late stage, it is like that. I call it as a trident shape. If you make a trident like this, initially it will be here, and later here, and later it will be like this, sir. So you can just remember like that.
Great. So typically, higher frequencies are affected more.
Sloping sensorineural hearing loss.
Yes.
This noise-induced hearing loss, sir. 4K had dip is there, sir, in noise-induced hearing loss.
Oh.
That is very important.
Noise-induced hearing loss, there is a 4K, 4000 frequency hearing loss. Right.
So this you can say. Yes, sir. Carry on, sir. Carry on.
Yes, sir. Yes, sir. Please.
So this will be there in the Meniere's disease, sir. As we have seen the improving pattern, and then as I told you, in Meniere's disease, you remember if Lord Shiva's trident is there like this, initially you bend it like this. Initially it will be falling, then it will be neutral, and it will be raising like this. You can just see in the textbook also. Initially lower frequencies are affected. Why like this means? So because the cochlea is getting enlarged and then decrease, enlarged and decreased. Every time it enlarges and decreases, there is some amount of addition of the hearing loss. So based on the addition of the hearing loss, it has got rising pattern, falling pattern, and then stable pattern, something like that. So in different stages. This is only an explanatory way that you can just understand. This is a question that can be given for theoretical purpose.
Great. Then where do we see this kind of an audiogram, sir? So
this type of audiograms, crust-shaped audiograms, sir, there are different audiograms will be there. Like as you could see, dip in the bone conduction curve will be in the otosclerosis, and crust shape like congenital sensorineural hearing loss, as you can projected in this particular example. So in the middle frequencies are affected. So this is falling down and then this is going up, something like that. So you can say trough shaped or crest shaped, as you could see, or like bowl shaped. So different hearing loss are there. These are theoretical questions. Generally, we don't encounter these patients very much, but theoretically important as far as NEET and these entrance exams are concerned.
This is very practical. Yeah.
Yes, sir. This is, as you could see, the dip in the bone conduction curve. So Carrat's notch, it is called as Carrat's notch, and it is because of the Carrat's effect. And then this Carrat's notch completely disappears after the surgery. That is the important point you have to remember.
Oh, after surgery, otosclerosis, do we do the
improves?
Okay.
It improves, sir. It improves.
Regularly?
Yes, sir. Successful surgery, sir. After successful surgery.
Oh. Now, coming to the fistula test, we have a positive fistula test, negative fistula test, and false negative fistula test. So what is the inference of that, and where do we see that?
So fistula is very important, sir. Fistula is, as you know, that like it's like a connection between the outside and inside, as like a surgical definition. So when we are trying to increase the pressure, for example, put a Siegel's speculum, and there is a connection between the lateral semicircular canal or any part of the inner ear and then to the middle ear, and you are increasing the pressure, it causes the pressure to be increased towards that. So towards the inner ear, and it causes nystagmus and vertigo, as you could see here. So positive fistula test, when there is a fistula, when you are able to see, as you could see here in this inference. So in the normal individuals and also in the sensorineural hearing loss as positive fistula test, as you could see here. So negative fistula test, sir. I think this is related to that the tuning fork test, sir.
Oh, I'm sorry.
Tuning fork test, not an issue. The slide is related to tuning, not an issue, sir. We'll complete the fistula test here. Not an issue. So when you are having a fistula and you are trying to increase the pressure, it causes pressure on the middle ear and then inner ear, and then it causes vertigo and nystagmus. That is a concept, simple concept. So when the fistula is blocked by some cholecystoma or it is blocked by some mechanism of healing, so then fistula is there, but fistula is negative. That is false. That is a negative fistula test, as you could see. So when you could find it in that. And here, especially this false positive fistula test. So false positive fistula test is very important. You can just remember by CM. That's it. CM, false positive. So these CMs and all, they do give false positive, assurances. Is it or not? So you can remember like that. Of course, I'm not putting any derogatory comments. Just for remembrance, CM gives false positive assurances, like false positive test without fistula. So without fistula, we have got that, especially in congenital syphilis and Meniere's diseases. It's called as something called as Hennepin's sign. So it is abnormal attachments between the stapes, etc. All those things are the reason for the false positive fistula test that is present. So false negative is, as you could see, when the labyrinth is dead, however fistula is there, there is no conduction from the lab, that is inner ear to the brain. So that is false negative fistula test. The fistula is there, but there is no inference there. And even cholecystoma, as I already told you, that way you can just understand, right? So how is it done? Means it is done with the help of a Siegel speculum or putting pressure on the tragus. Just simple pressure, inside pressure on the tragus.
Great. So coming back to our earlier question of Renis being positive, Renis being negative and false negative, how do we remember that?
Just simple that Renis, as you could see, one of the important tests for air connection and bone connection. This is a tuning fork that you are trying to vibrate and put behind and in front. So when you are saying that Renis positive, so Renis positive is a good thing, especially it can be normal or in the sensorineural hearing loss, as you could see here. So this is the air connection and this is the bone connection. So whenever there is conductive deafness, that is when this air connection is lost, so bone connection takes over. So bone connection is better than air connection. That way you can remember. So simple concept is air connection and bone connection.
Now coming to the Rini, we understood where how do we do Rini, how do we do Weber, and the Schwabach's test.
So as you could see, the Weber's test for the lateralization, like you are vibrating and then putting in front of, you can put it on the brow or put it in front of the nasal bones or the teeth or in the above the vertex level. So Weber's test is lateralized to the worst ear in case of conductive hearing. There's a big question every time. People get confused. The understanding is very simple. Like you have got a shortcut is provided by the nature called as air connection. Normally, even if you don't have ears also, you can hear with your this vibrating skull. So that is a concept. So when I vibrate the skull like this, inside cochlea vibrates and you are able to hear. That is a bone connection. So, but nature has given one more extra step, that it has provided a shortcut to go towards this particular hearing, that is called as conductive hearing loss. When the shortcut is lost, so the patient tends to hear through the bone only. So that is why the Weber is lateralized to the worst ear in the case of conductive deafness. Why it is worst ear? It is lateralized means we are putting on the bone. So bone is more active on the conductive deafness side. That is why it is lateralized to the worst ear. And then absolute bone conduction test, when you say, and Schwabach's tests are almost all simple. Like, so when you are trying to vibrate a tuning fork and try to close your canal and then put it here and then put it on the patient. So if you are hearing more than the patient is having sensorineural hearing loss. Schwabach's is also similar to that, and you don't try to close it.
Right. So in the normal individuals, there is no lateralization of sound because the bone conduction of both ears is normal and equal. Whereas in conductive deafness, the lateralization of the sound occurs to the diseased ear, and the sensorineural hearing loss, the lateralization occurs to the better ear. But this is a very good analogy you told, said that air conduction is in fact a shortcut.
Yes,
Air
sir. Yes, sir.
conduction is a shortcut. If we have ears, is a shortcut. But even if we don't have ears also, if we vibrate on the bone, still the cochlea picks it up, which is the bone conduction. That's a wonderful point. A very easy way to basically remember. So that is
Yes,
the
sir.
reason whenever there is any conductive deafness where the air conduction is not happening, the lateralization typically occurs to the diseased ear where the bone conduction is still intact. So, right. Now, bilateral hearing loss occurring in a female 25 years of age and accentuation of this hearing loss during pregnancy. All these points, the clinical vignette towards which condition?
So something called as otosclerosis, sir. Most commonly asked question, especially in the MBBS exams, also they put this as a clinical question. So female aggravating hearing loss by means of pregnancy because of hormonal imbalances, etc., etc. So otosclerosis, that is a disease of the temporal bone, more commonly occurring at the fistula antifenestrum, that is in front of this particular stapediovestibular joint. So just more common in the case of females. So the treatment is, as you know, that sodium fluoride is a medical treatment, and that stapedotomy and piston fixation is the surgical treatment.
Great. Now, once more, this we already discussed.
Yes.
Type A is the normal tympanogram. AS is low compliance tympanogram with otosclerosis. AD is high compliance with ossicular discontinuity. Type B is that flat dome shape because the fluid, and type C is negative compliance seen with the eustachian tube dysfunction and retracted tympanic membrane. Absolutely. Now, different conditions, different decibels is another common question asked in the entrance exam in the NEET PG. Many times this question, it's a purely something that we need to mug.
Yes.
But one of the common confusion is ossicular interruption with intact drum is 54 decibels. Ossicular interruption with perforation, it is 10 to 25 decibels. Any reasoning in this?
Yes, sir. Something actually is something called as physiology of hearing comes into picture here, sir. Actually, Weaver-Lawrence theory, it says that the periphery of the tympanic membrane vibrates more than the center. So, according to some experiments, and the particular ossicles, that is called as preferential pathway, sir. So, preferential pathway. Once again, as I told you, the shortcut provided by the nature is these ossicles. So, these ossicles were like teeth in the fishes. So, they are modified by the nature. And by the way, humans developed, they are like as they are related to this gill apparatus, etc., etc. So they come for the rescue of hearing better. So when we have a tympanic membrane, sir, when you have a tympanic membrane intact, but ossicles are not there, it in fact the tympanic membrane is producing a obstruction to the sound. You can just simply remember like that. So the cable is being cut there. So conduction is not occurring there. But if the tympanic membrane is not there also as a perforation, so the ossicles can have some amount of conduction. So always remember, conduction is a shortcut that is provided by the nature. That
Great.
simple thing makes us understand this, sir. And as you could see, I'll tell you something easy to remember here also. So when you close your ears, just say, so 30 decibel simply, you can just remember like the 30 decibel here. And perforation of the tympanic membrane is a bit more than that, that is 40 decibels. So going inner and ear. Ossicular interruption with intact drum is causing 54 decibels. So just if you remember that, and with perforation means mostly they try to give the question in between these two only. Okay, 10 to 25 decibels. So you could see the perforation. Second one is also 10 decibels, and then ossicular interruption with perforation also 10 decibels. So this is like, what you say, it's a crude question or rude question on the students. Very difficult to remember this. After doing 5 to 10 years of service in ENT, we tend to remember it easily. But there is no point in giving. But the concept should be understood that conjunctive deafness is the key behind the proper hearing shortcut. If you understand that, this question matters a bit, value for that understanding. So,
Absolutely. So the last question for the today's evening, very close link between the neurology and the ENT is the vertigo. The peripheral vertigo versus central vertigo. Any points that you want to us to remember, or do we need to really remember this just like that?
no, sir, just as simple as that. I'll just say once again as a government example. So central government, state government. So central government is the CNS, state government is the ENT, ear part. Okay. So vertigo, as far as is nothing but the hallucination of movement. So as simple as that. So it can be because of central causes which are more dangerous. Central cause, for example, someone has a brain tumor somewhere in the midbrain or pons or medulla. So that is more dangerous. Tumor is there means tumor will be there forever and it has to be removed. Until then, vertigo will not go. So remember something like that. For example, central government orders. It is like a sharp point. Lockdown you have to keep means they will have state governments have to follow. So they will have to follow, and once something like that, central this related nystagmus, once it is there is nothing like a latency. There is nothing like a duration, direction, fatigability. Nothing will be there. Will be there. Whereas state government, that is vestibular system, as simple as that. Latency, duration, direction, fatigability. So because our people, because we give some amount of exemption for that, our state only, our local party, something like that. Central government is very rude. For example, I'm telling, I'm not blaming anybody. So in that way, you can just simply remember like that. So latency, duration, direction, fatigability, all these things will be there for this particular peripheral system. Peripheral system, especially, there are three things. So frontal nervous system, you have got the brain and all those spinal cord and all those connections, etc. Peripheral system, you have got visual system and vestibular system, and then somatosensory system. So remember your best test Hyderabadi player VVS Lakshman, visual vestibular somatosensory VVS. So VVS is the peripheral vestibular system, and you should have a basic idea about the nystagmus also, something like push-pull mechanism. So if it is a eye problem, so always ENT and ophthalm departments are side by side together in the medical college also. So as like in our body. So this vestibular system and visual system are linked together. So when you say the pendular system, like pendular nystagmus is there equally moving like that, it could be probably this particular visual part, visual related this nystagmus. And especially I'll try to brief the nystagmus also. Why the nystagmus should be there? So nystagmus is the hint for us that there is something wrong in this particular systems, which is a hint for us. So irregular rhythmic oscillatory eye movements, irregular IRO, so not ISRO, IRO, irregular rhythmic oscillatory eye movements, which say that there is some problem in the eyes or this particular ears, that is vestibular system. So which is their connections. So it is just like a hint that is given. Without investigation, you can see that. So 30 centimeter distance you have to keep and then see the nystagmus. These are all basics I am telling. I'm not going to details, only for the understanding. So visual system nystagmus is something like a pendular. And especially the vestibular system is jerky type of nystagmus. So smooth movement is there. Hello.
Yeah.
Smooth movement is there. Yes, sir. Audible, sir. Smooth movement is there means you should think of eye related issues. These are only basics. Now to go into details. And there is jerky. There is something like jerk, something like that. So it is related to the vestibular system. And so up and down movement most commonly related to the central nervous system. So all these things that are there, the table which you have given, sir, most of the things are covered, which I told you right now. Most of the things can be read from the table, and this is a basic concept behind that. Whenever there is a vertigo patient, we have to rule out whether it is a central vertigo or peripheral vertigo. So peripheral vertigo, especially like BPPV, is the most common. So it is called as benign. The name itself says benign paroxysmal positional vertigo. In particular position, you take the particular position, especially the Dix-Hallpike test. As you know, the details of it, Dix-Hallpike, you see in a particular position, there will be a latency, there is a duration, there is a direction, there is a fatigability. Fatigability means once the vertigo comes, after that the vertigo subsides slowly. So the first attack will be more severe, and later on the attacks will be a bit okay for the patient. So you can also say that it is a benign condition. So fatigability will be there. Don't worry. You have to see. And at the end of the day, if a student is intelligent, so the vertigo patient first goes to the neurologist because he has got very fear anything in the brain. Okay. And then he'll be referred there. From there, all the departments go. At the end, he'll land ENT department. So that itself says that it is a benign condition. And we have to give some maneuvers. Of course, neurologist also gives. We also give. And by the way, if there is any problem like CSOM or any cholesteatoma or anything eroding the labyrinth, that is to be seen by the ENT, and then it is a surgically repairable thing. And Meniere's disease also, there are some surgeries. And whatever, the BPPV also can be managed by the ENT. So it's like a combined department, like neck by surgery, and then the anesthesia people, and then ENT people. Neck is handled by everybody, like tracheostomy done by everybody. So vertigo is a combined topic. So gross idea which I have given.
Great.
Hopefully, I think
One easy way to remember is, as Chandrasekhar said rightly says, central is something that has no rules, nothing. So no change, no, it is absent, no, nahi, is central. And another thing is central is purely vertical. That means if something wrong in the brain, we straight go to the heaven. So it is purely vertical. Whereas here in the periphery, it can be horizontal or torsional. If it is ocular problem, then it is smooth. And if it is vestibular problem, then it is more jerky in nature. And fatigability is a characteristic feature of the peripheral because it is most of the times benign. And a lot of patients also know that in the benign paroxysmal positional vertigo patients, even if she is a housewife also at the age of 60, 65, she knows very well that how to get up slowly from the bed and how to do the neck exercises. And this is not going to be there forever and it is going to fatigue. That's what even a grandma with or a housewife also can be able to tell about the fatigability of the benign paroxysmal positional vertigo. As an undergraduate, I often used to have this as a tough topic. But the first time I was very easy with the topic is after talking to around 4 to 5 of the real patients of the benign positional vertigo who will actually demonstrate and show you what are the positions where they get it. Then that is like reading Harrison about 100 times. So that way, wonderful. So where do we see pure vertical nystagmus, downbeating vertical nystagmus, upbeating vertical nystagmus, purely rotatory nystagmus, and pure horizontal nystagmus? This is one of the favorite NEET PG MCQ for the nystagmus. Yes, sir.
So vertical nystagmus, downbeating nystagmus are also all related to CNS, sir. As you could see, the first point. So pontomedullary junction or cerebellar lesions or vestibular basilar insufficiency. So these are something to be remembered theoretically. Downbeating, as you know, Arnold Chiari malformation, cerebellar degeneration. Yes, sir. And purely upbeating, pontomedullary junction. So upbeating means you have to look up toward the PM, pontomedullary junction, and pons and midbrain. So you look about the pons and the midbrain. That is something related to central nervous system, especially in the axis. Okay, purely rotatory, as you could see in pendular syringomyelia, and purely horizontal and cerebral lesions. So these are a bit of more something related to CNS rather than ENT. So mostly we have to remember these things.
Absolutely. So quickly 10 points about the benign paroxysmal positional vertigo that we can have in our tips for the NEET PG exam, sir.
So BPPV, the name itself says benign, not dangerous, paroxysmal, suddenly occurring, positional to a particular position, vertigo will be there. So when we have got the otoconial debris, sir, so we have got some small, for example, salt-like granules in the posterior semicircular canals. So when it is when there is movement, they get settled one place, and then when it is moved to a particular head position, so particular, for example, right lateral or left lateral position as well as head hanging position, when if it is there. So when they touch generally this debris, whenever it touches, it causes stimulation of the particular thing and causes a geotropic nystagmus. Towards the earth, there will be nystagmus, something like that. And more commonly, it can be because of the trauma or it can be because of old age, degenerative condition. And it is a fatigable, as you know, BPPV, all the points you have to know about the peripheral vertigo, you can just say that. And it may be associated with nausea, it's a point. And latent geotropic fatigable, as we have already seen. So latency will be there. So 10 to 15 seconds latency will be there. And it means it takes some time to manifest when you are putting. Diagnosis is by means of Dix-Hallpike maneuver, and treatment is by means of Epelys maneuver or Simon's maneuver. Epelys maneuver or Simon's maneuver. And there are a lot of maneuvers which are not important as far as the entrance exam is concerned.
Great. So, last question for the evening. Elderly diabetic, painful ear discharge, facial nerve palsy, no response to treatment, and decreased uptake on technetium bone scan. So, all these are highly suggestive of what diagnosis?
So, it's a misnomer, sir. Actually, malignant otitis externa, pseudomonas infection. So, malignant otitis externa, especially called as skull-base osteomyelitis. So, what happens is it presents with, I'm telling that it presents with granulations in the external artery canal. Normally, external artery canal doesn't have any granulations, something like that. But there is an inflammatory change, rapid inflammatory change that is present in the external artery canal, which you could see it is not getting decreased, and patient has got very much painful, especially like as you are seeing this black fungus cases nowadays. It is a diabetic related, immunocompromised related, debilitated, or organ transplant. We see in the ICUs generally. They call us for ENT opinion, especially in the ICUs who are debilitated and elderly. And painful ear discharge. The pain is very important. So for that reason only, initial days they might have called it as malignant otitis externa. And especially associated with facial palsy. Facial palsy is very important. One of the important nerves that is related to that particular thing is the facial nerve that can be getting. Patient may be presenting with facial nerve palsy only. And technetium bone scan is for this one, and especially caused by pseudomonas. Generally, we give antibiotics, especially ciprofloxacin. That is one drug which we give for weeks together. Orally also, some patients we have seen patients healing orally also with oral treatment with ciprofloxacin also for 3 to 7 weeks, something like that. We try to give.
Right.
And hint should be there, sir. That is called as skull base osteomyelitis. It goes towards the skull base, and then it should be debrided. If it is going to osteomyelitis, if it is there, means you have to debride, and then you have to do surgical repair also sometimes.
Wonderful. So that brings us to the end of this wonderful. Without knowing, we finished about 1 hour. Whereas when we are didactically teaching, sitting alone, 1 hour looks very painful. But this 1 hour of discussion looks like having a ward rounds with Dr. Chandrasekhar. And thank you so much. And we'll have many more sessions and vibrant evenings like this. And thanks all, Rishabh Shetty and everyone joining the session. And coincidentally, Incus is a very favorite name for us. And now the edutech startup that we started is also called as Incus. And we want to revolutionize learning. Today, about 50,000, 60,000, 70,000 rupees students end up in paying in the coaching programs, plan A, plan B, and all these things on the mobile app, face-to-face classes and all. But we made it only 333 rupees 1 year, or 999 rupees in 3 years, which is only 1 rupee investment is all that you need. And at the same time, you get the most qualitative learning with almost 800 hours of video content and 60,000 MCQ question bank and 60 full-scale grant tests with discussion and daily live online interactive session with some of the wonderful teachers. And I'm really humbled that the once upon a time the students become consultants, become toppers, and they come back and give back to all the students is something that is the most relishable experience for a teacher. So thank you so much once more, and we will catch up in the further sessions. Thank you.
Thank you very much, sir. You are called as pioneer of this medical entrance coaching, and we are all your followers. And thank you for giving the opportunity. We are very happy. Once we were your students and we are able to sit inside, side by the side of you. That is a big thing that we can say for ourselves. Thank you very much.
Thank you.